All, this is Dr. Mubin Sayed from drbeen.com. Welcome to an open forum. This is a heart-to-heart, and I am amazed. I am excited about the questions that are asked on Twitter. So here is the way we will work today. What we will do is we'll go over the questions that are asked on Twitter, and then we will go over the questions that are here in the stream as well. So do me a favor, when you have a question here in the stream, please put the word question with it, and let's start. So welcome. So today is our discussion. So I can actually, ITJ, welcome. Jim, welcome. And please make sure that you have the questions. Chantal, welcome. Sunil, welcome. All right. So very, very welcome, Aslam, from Dr. Hussaini. Great to see you as well. Diversity, welcome. Love you all as well. So thank you very much for being here. There are some exciting questions today, and I really think that it would be interesting to talk about them. I am so proud of the cool beans and the questions. These are so thoughtful questions, and these are so probing and deep questions that I enjoyed working for them and preparing them. So let's start. So the first question here is from Leon Holloway. She's saying that how scalable is COVID-19 recombinant hyperimmune? Can they make millions or billions of doses? Also, is it a treatment or prophylaxis? So good question. First of all, please realize that it is a similar thing in terms of when to give as convalescent plasma. So this is a treatment. It is a short-term treatment. Probably once those antibodies are given, they will live in a person for up to 2 months. These antibodies are usually slightly modified so that their life is increased. So these are like convalescent plasma, or these are like monoclonal antibodies. But the thing is, the number of antibodies are too large. So it is a treatment option. It may be prophylactic as well, but again, the duration of the monoclonal antibody, so the antibodies to live in our body is going to be 2 months. So if you give it for prophylaxis, it's about for 2 months. So that is the answer. Now, the scalability, I was thinking of actually reaching out to that company and invite their CEO to talk with us, and we'll ask these questions from them, because I do not know what is their own capacity. So very good question. Then Mahmoud Tony says, the Russian vaccine, some articles said that they object to the launch of the vaccine as it cannot have passed all phases. How does it apply? So I have had many questions about the Russian vaccines. So generally, let me put, there are some more questions down here as well. So let me put the Russian vaccine discussion for how much I know in front of you. And there will be, I believe, some. So here is an article as well. And all of these articles, I have put them in the description as well. So you can see them there. The vaccine type for the Russian vaccine, the vaccine type is adenovirus. So remember, this is a traditional vaccine type. Vaccines are many types. For example, you take up a virus or a pathogen, you break it apart into smaller pieces, you kill it, and then you give those parts as a vaccine. Or very commonly, we take an adenovirus. It is pretty harmless. And then we gut it. We take its genetic material out, and we add the genetic material, for example, spike protein from coronavirus material in it, and then we inject that virus into the that weakened, attenuated virus, which is modified as well, into the body of the person, and then that virus will be picked up as a virus, and the body would learn how to respond to the spike proteins that it will be making. So Russian vaccine is this kind. This is a similar vaccine which is Sinovac has worked on, and this is a similar vaccine which Oxford has. So this is not a newer technology messenger RNA type vaccine which Moderna or Imperial College has, but this is a traditional vaccine. Now the question is, how reliable is this? What is the results? I have not been able to see the results for trials. Maybe I was not able to find them. Maybe these are in Russian somewhere, Russian language. So if somebody knows some English data for these, that will be great for me to look at. They say that they have done the phase 3, and somebody said that the phase 3 is because they had been working on it for 6 years. This has been the case with the SARS Oxford vaccine and Sinovac vaccine as well, that they had been working on a vaccine for SARS-CoV-1 and MERS-CoV years ago. And then those projects were stopped because the virus disappeared. But they had all the platform ready. So when the SARS-CoV-2 came in, they had a head start and they started working on it. For the Russian vaccine, I do not know if they had the similar preparation before, but somebody said that they had been working on it for 6 years. Maybe, and if that is the case, it is a good thing, but I'm not sure. The other thing is, I'm not sure about the results. So can I sit here and say that they are ready to go live and in production? I can't comment until I see the data. So that is my position on the Russian vaccine. At least from a technology point of view, I understand the kind of virus is a traditional vaccine. So from that point of view, it should be okay. All right, so continuing on. Pandemic infection can alter or weaken the virus mutation, replication, and repair process in longer duration. Your view. So this is a very interesting question, and we have done this discussion in the past as well. And the discussion basically is this, that let's say if we have a virus here, and this virus needs to spread. We have done this discussion in the past as well, that when a virus is going to spread, when a virus arrives in a body, there are 3 outcomes. When it replicates in the body, it would actually make, let's say, more viruses of the same type. That is one possibility. And in case of coronavirus, that is a larger possibility because coronavirus has a proofreading enzyme. So there is an enzyme when the new virus is formed, that enzyme proofreads the genetic material and makes sure that it is as the original one. Still, the mutations do occur. So it is possible that a virus like original will be formed. And if that is the case, then the capability to spread and infect will be similar. It is also possible that a virus is formed that is actually weaker. Maybe their spike protein is kind of not correctly formed, or the shape is not right, just like somebody may have, congenital abnormality. So let's say the spike protein is not good enough and this virus cannot bind to the SARS-CoV, the ACE enzyme. So this virus is going to die. So this will not propagate. I can call this as a weaker virus because it cannot really bind and go into the cells, but then this virus is not going to spread. And so weaker virus is not going to go anywhere. Then it is possible that there is another virus which is probably weaker. And let me explain what does that mean. It may have the right spike proteins, but it is weak in causing the symptoms. Such a virus would actually then start spreading faster because people with lesser symptoms, for example, children, and imagine if there is a virus strain that causes the similar thing in adults as well. And so the adults have lesser symptoms. They would now be going around, they'll say, well, it's not a big deal. The symptoms are mild, I can work, and they would be spreading it fast. So such a weak virus, which can still have some functionality left in it, but the symptoms are lesser, that weak virus would spread faster. Then imagine that there is another generation of this virus, and this is in the same one person, that various kind of copies are forming and they have mutations in them. So let's say this is another virus, it can actually bind and spread, but this virus causes too much of the immune response. This virus causes too much of the cellular damage. So this is a stronger virus. If that is the case, the stronger virus is actually going to be destroyed as well, because what will happen is it will cause infection in a person. That person would, because of the aggressive behavior of the virus, that person is going to die, and this virus would die with that person. So this virus, a stronger one, cannot propagate further easily. A weaker one, which is too weak, can also not propagate. So the one that would propagate is going to be either the one that is originally propagating or something similar to that. So then if you look at the answer here, that can the virus will it become weak after the mutations? Yes, it can become weak, but depends upon what kind of weakness it has. If it cannot replicate, then it is not going to go anywhere. If it cannot bind with ACE2, then it's not going to go anywhere. If it has become too aggressive and kills the person in which it formed or the next person where it goes, they would die, and that virus is not going to go anywhere. Only those pathogens can spread easily that can accommodate the host to continue to walk about and spread. This is especially for the respiratory viruses. So I hope that answers that question. Leon says, RNA vaccines, do they have a proven track record? Is it risky that so many of these initial vaccines are RNA, potentially putting all eggs in our basket? So a couple of things for the RNA vaccines. And I want to make sure that there are a couple of questions about the liposomes, and they are important. These questions are important for RNA virus as well, and for vitamin C question as well today. So let me talk about RNA virus a little bit. And we have talked about these things in the past as well. Look, the RNA virus, what they're doing is they have a lipid particle. So let's say this is a lipid particle. That means the wall of this is made of the phospholipids. It is a similar wall that our cells have. And this, inside this particle, we have RNA. And this RNA has a genetic code to make spike protein. Now, what will happen is when this lipid particle is injected into our body, the cell, so let's say it is injected into a muscle tissue, let's say deltoid, the upper part of the arm. So once it is injected there, what will happen is that the macrophages over there are going to eat it up. They are going to eat it up and break it. Normally what happens is that the lipid membrane here, this membrane becomes fused with our membrane because their quality is very similar. Some of the lipid particles are actually decorated with the proteins on them that allow them to be eaten up by macrophages with more ease. So there are various decorations we do on the lipid particle that makes them easier for our cells to pick them up and internalize them. So once it is internalized or fused with the cell's membrane, the RNA would now enter the cell. And now that cell has the RNA. And many people have said to me that this RNA is going to go and modify the DNA. No, that is not the case. This RNA is just going to stay in the cytoplasm. It's not going to go in the nucleus. And over here, our ribosomes will work with this one and make protein. So because this is not the complete virus genetic material, it's only for the spike protein. So what will be formed are spike proteins. These spike proteins will then be presented on the macrophage surface, or their epitopes or their pieces will be presented. That would cause the immune system to start becoming active. We know that naive T cell will be here, then T helper 2, then B cell, and then the antibodies. It is also possible that T helper 1 pathway will be taken and cytotoxic T cell will work. So that is how a liposomal particle will work, and that is how the RNA-based vaccine will work. The difference between Moderna's vaccine and Imperial College vaccine is that Moderna's vaccine does not have a replicating enzyme in it. So whatever is the dose given from outside, that is the dose of the particles that will go into our body. But in case of Imperial College vaccine, there is an additional enzyme RNA added to the RNA of the virus, the spike protein. This RNA, when it goes into the body, into our cell, I shouldn't say body, into our cell, it then causes the production of an enzyme, just like RDRP enzyme with the virus, that allows the replication. This enzyme is going to allow the copies to be formed of the RNA, spike protein RNA that was injected. So what would happen is that enzyme would help increase the amount of RNA, and then inside the body, more RNA will be produced, more spike proteins will be produced, and that's it. The benefit of Imperial College vaccine is that they can give a smaller dose, which would then become replicated and increase. But again, remember, it is not a virus, it is just a spike protein. So even when it replicates and increases, all it makes is just the spike protein. Maybe that's just a hand, for example. It's not going to make the whole baby, just the hand of the baby. And so that hand can do nothing other than being presented on the cell, and the immune system recognizes it and attacks it. So that is how the RNA viruses work. Now, RNA vaccines work. The question now was that, is this something that have a proven track record? No. And I have done a detailed discussion about it, that there are so many things that are yet not known, and that is why the trials are there, to understand the efficacy and safety and dosage and the side effects of these kind of vaccines. But these are newer vaccines. Traditional vaccine, for example, Oxford's vaccine or Sinovac's vaccine or many such other vaccines, they are mostly made with the coronavirus or weakened virus, which we know are traditionally used. So I hope that answered this question. So also this question that potentially putting all our eggs in a basket, that's not exactly true, because there are Moderna, there is Imperial, but there is Oxford as well, there is Sinovac as well, there is CanSino as well, there is a company in India, there is a company in Israel. So there are companies all over the world that are making vaccines. There are 200 types of vaccines or more. So no, we are not putting all our eggs in one basket. Good question though. Then Gajanan Kulkarni says, if vitamin C is given orally, body can tolerate only 500 milligram per day. Does this limit increase if it is given in the form of liposome? If yes, does it benefit body more in terms of immunity? So very good question. And I will, again, I have put the description, the link to this study. So this is a study which compares the liposomal vitamin C to oral vitamin C and to injected vitamin C. So once again, we are already here and we talked about the lipid particle. Now we're going to talk about the lipid particle in terms of vitamin C. So here is what happens. So what we do is we make a phospholipid membrane particle, just like our cell has a membrane. And in that particle, we put, let's say, vitamin C in it. So this is vitamin C. So we kind of store vitamin C in a lipid particle. When we give this lipid particle, it can actually be absorbed in our GIT. So if it is our intestine, this lipid particle absorbs better in the GIT compared to if we had given vitamin C alone. Correct? So what they did was, the study that I just showed you, this one, they gave 4 gram, I believe, 4 gram of vitamin C orally without any lipid particle or liposomal. Then they gave 4 gram liposomal vitamin C, and they also gave 4 gram of infused vitamin C directly given into the blood. And what they found was that the best bioavailability of vitamin C came from the IV. Second best came from liposomal because it had better absorption. And the third best came from the oral availability. Although, because the doses were high enough, all of these forms had their action available, and that action was equal. And that was not because they were all available correctly. It is just that the dose was so high that even oral vitamin C without liposomal form had such a high dose that enough of vitamin C had become absorbed and was valuable. So liposomal has better absorption compared to non-encapsulated vitamin C, and the best is intravenous. So then going back here, and there is another article I have left here, what is a liposome? So if you wanted to see what is a liposome and how does it function and what are various ways that we use it, then that topic is interesting. It is interesting both for mRNA vaccines plus for the liposomal drugs. Then there is another question from Gajanan Kulkarni. What precaution and supplement medicine you will recommend to people who have recovered from a coronavirus to get back to their original life and get good health? So again, there is no prescription for anyone here. These are just educational and informational videos. So no prescription here. This is not something that is directed towards any one person here or more people here. This is just education. Look, somebody who has recovered. So there are two categories now. We know that there are long haulers and there are people who actually recover fully. So somebody who has recovered fully, I would still ask them to continue to take those supplements that are needed. For example, vitamin D and vitamin C. And I would even say keep taking zinc and quercetin, and keep taking CoQ10, so that maybe melatonin, low dose, just so that your own immune system stays healthy and happy. But the chances of reinfection, at least within a small window of time, are not possible. And we'll talk about the decaying antibodies. There is a question about that as well. So that is how I would give the supplements for such folks. But generally, they have recovered and they should be okay. This may be that they might need multivitamins for strength and to regain the strength. So that would be good nutrition, lots of water, exercise, good sleep, less anxiety, and good multivitamins. Okay, continuing. So one more question from Gajnan Kulkarni. The good news is that after so many questions, I can start pronouncing his name correctly. I wonder why is zinc liposome are not being considered as a medicine for COVID-19? This is a very interesting question. So what he's saying is that, remember, we say that here is a cell, and in this cell, zinc cannot enter because the cell membrane is phospholipid, and that membrane is neutral in its function, and that does not allow charged particles to enter the cell very, very easily, or charged particles cannot enter. So for that, we need zinc ionophores, or we need channels for the zinc. That causes, for example, hydroxychloroquine is such a channel possibly, and then quercetin is such a channel, and there are other zinc ionophores as well. So Gajnan's question is, why not we wrap zinc into a liposome? And I love that idea. Yes. So let's say this is a liposome and we put zinc in it. As long as the zinc charges are not taken away because of the pH alteration that can happen in the liposome, if that can be taken care of, then this liposome can go and either fuse with the cell membrane, it can be constructed in that way, or it can be taken up as an endosome and the zinc released inside the cell. So that's a very good idea, not bad. So we have cool bean scientists here as well. So Luke says, what do you think of the Russian vaccine? So I just talked about that. So I'll leave it at that. Do you think we will be worse off in the fall and winter? So Luke, that is an interesting question, that what is going to happen in fall and winter? So again, we haven't yet lived in any one geography. We haven't lived through the whole year and all seasons. However, we have lived through various seasons in various geographies. Now, it is possible that geographical changes have their effect, cultures have their effect, habits of the cultures have their effect. So maybe I cannot say that what happens in New York in the same temperature should happen the same thing should happen everywhere in the world in the same temperature. But there was a study from China where they said that virus propagates lesser in the colder environment, in the warmer environment, and a little more in the cold environment. But that was just one study. This is a very good question, and I think we'll have to keep an eye on this one as we go through more months, and as any one geography goes through all the cycles of the season. We'll see what happens. I have my own opinion that the virus propagates less. So moisture can cause the virus to propagate more or less. So here is how that works. And I've done a discussion about the temperature and moisture separately. But what happens is that, imagine this is a unit area. In that unit area, imagine there is no moisture at all. So just a hypothetical situation. So if in this area, if you put the virus in here, coronavirus especially, because it is an enveloped virus, and if there is no moisture around it, this virus is going to very quickly lose the fluids from it and become shriveled, and it would become less viable very fast. So that is a lack of moisture. Now, if you put some moisture in here, then that would allow the virus to be able to equilibrate with the moisture and kind of live a little bit better. So at an optimal moisture, the virus would stay viable for a longer time. So when it is being transmitted from a person, it may keep going for a longer period of time and still stay viable. On the other hand, if there is too much moisture, So let's say the moisture level is really, really high. So now what would happen is that the virus will find it difficult to move through the moisture because that is a thick medium for it to move through. And so the breath may not go too far, and a person who is maybe standing lesser than 6 feet may also not get infected. So moisture levels, I can't just generally say that in moisture it would work better or not. It depends what is the optimal moisture, and below that or above that, the virus will not propagate correctly. Okay, so continuing on. There is one more question. In India now, we have humid and rainy weather and temperature is 24 Celsius. You said in past, humidity reduces spread. So I just talked about it, that what is the role of humidity. So people are saying that the virus will be promoted in the rain. What do you think is right? So look, rain is a totally different thing. Of course, the moisture is increased, but now we have water as well. This virus loves to live in water. So the wet surfaces would allow it to live more and better. So the rain itself can actually clear the virus from the environment, but then whatever surface it would drop on, if that stays wet for a longer period of time, then virus has a chance to live there viably for a longer period of time as well. Okay, so the next one, can we get any immunity from dead virus, which we may pick up from the surfaces? Roshan asked that question. Beautiful question. Depends upon what is the dose of the virus, but just know this thing, that the virus on the surfaces is either going to come from a person's snot or the nasal secretion, or from his spit, or from his eye secretions, or from his fecal matter or urinary matter. So all of those are not something that we would like to kind of touch and then get contaminated and then hope that we'll develop the vaccination from that. Now, the question really is there enough dose of the virus there that when it enters, let's say, our mouth, then it has a chance, if it is broken pieces are not going to have a chance to connect with the ACE2 and enter there. So they're just going to sit in the moist area. So are there enough cells there in the moisture or the moist surfaces that can pick up the virus and then develop the immunity? I don't think that is possible. Plus, we normally have immunoglobulin A's that are present in the moist surfaces, which can try to bind the virus and keep it away from the cells. So I don't think that we can develop immunity. We can definitely develop infection from it if we have gotten enough of the virus load into our mouth, and that virus then is able to capture the cells and get into them and cause the infection. And many people may touch a surface and touch their mouth and still nothing happens because the virus load was not sufficient or the immune system responded. But it will not act as a vaccine. So please don't do that experiment. So Pizzo says, do you take hydroxychloroquine or ivermectin? I will pass on this question. Good question. Relogiro says, are the upcoming vaccines safe? So I just had that discussion that the vaccines depends upon, the newer vaccines can have an issue which we are not aware of yet. The older vaccines, traditional vaccines, should be relatively safe. But again, the trials should determine that. What does active not recruiting mean? And so there was an answer from, so Joey asked that, and answer is right below. Excuse me. Active not recruiting for a clinical trial means that the trial has become filled. The number of participants that they needed are there, and they're not recruiting more participants, and the trial has become active, and now they're working. Then there is this KPOP super strong. A super strong cool bean is here. I had fever last February. Usually if I had flu, I will recover in 2 days, but had high fever after 4 days and 7 days to get rid of my cough. So 4 days high fever, then 7th day cough was subsided. By mid-March, I experienced increased blood pressure and heart rate, then got blood test saying I'm developing diabetes cause of liver enzyme. Is this COVID? So if the last Feb means 2019 February, then I'm not sure. I do not know what is the area where KPOP is from, but I do not know if the SARS-CoV-2 was present in the world at that time. And then secondly, the viruses usually do not cause high-grade fever. That is usually some sort of a bacterial infection on top of it. But this would be very drastic that, again, I do not know, KPOP, what is your age, what is your demography? Maybe this was the age to have the diabetes and that is why it happened. So I can't comment really because I do not have more data. Ronald says, blank et al. Interest of proton pump inhibitor in reducing the occurrence of COVID-19. So this is the basic question over here is, we know that famotidine is known to help with the COVID-19, which is a H2 blocker or histamine channel blockers. Proton pump inhibitors are also given for acidities. And he's saying that there are a couple of studies. One study says they're useful and one says they're not useful. So what do you think? And then he's talking about lansoprazole. Is that an exception or not? So I will, Ronald, I will have to look into this one before I can comment into it. Today, I did not get a chance to actually go and look at both of those studies. For the next time, I will look into these studies and talk about it. Paul says, would adding the following to ivermectin doxy to be a sound approach? So to the early treatment. So antivirals, immunomodulations, immunosuppressions. So look, in the early time, this is still a discussion that is very, very interesting. Adding antiviral, which are antiviral for this kind of a virus, can be useful. For example, RD-RP blockers are useful, or antivirals which become the fake raw material, they can be useful. So antivirals can be useful. Immunomodulators, I would say that instead of immunomodulation, if we can give immuno-optimizers that can keep the immune system balanced, then that are necessary. Budesonide is an immunosuppressant. It's a steroid for the lung area. I am not sure. So when we talked with Dr. Richard Bartlett, he said that he used it in the later stages, but his colleagues have been using it in the early stages as well. I have seen in other countries that giving steroids early on are actually useful. But I hesitate doing that. I've said it many times because WHO had a study which we looked at as well, which says that the suppressing the immune system in the early part of the infection may cause the infection to spread more. So that is the answer for this one. Losartan to control the renin-angiotensin system imbalance. So that is a angiotensin receptor blocker. And we have been talking about this one topic for a long time. So look, we know that this is a cell here, and we have the ACE2 enzyme here. And then coronavirus connects here to enter our cells. First of all, the angiotensin receptor blockers, I am not sure if they work on ACE2's receptors. So can they block ACE2? We do not know, number one. Number two, there has been so much speculation that some folks say that it should actually help. Others say it should not help. American Heart Association and American Heart Association for Hypertension as well, they simply say that there is no deterministic proof for one way or the other, and people who are taking ARBs should continue to take it, and people who are not taking it should not start that for the virus. And the people who are taking it should not stop it. So that is the guidance so far. I am actually intrigued about this one, and this one question is still not solved, that ACE inhibitors and angiotensin receptor blockers, do they have any value to prevent the virus attachment to the sites? So good question. Mohammed Ghosh says, good morning, doctor. What are the post-COVID effects on our body parts? I read somewhere that it severely affects the heart if we need to go for MRI, CT scans of the heart after we have cured. So very simple answer. Look, it's not necessary that everybody's heart is going to become damaged or the lung is going to become damaged. Some people just get upper respiratory tract infection and they're okay, or they get GIT infection and they become okay, or they get a headache or fatigue and myalgias or the muscle pains and some fever and they become okay. So I don't think that such folks would have cardiac issues. It really depends what is the extent of the damage. If somebody had become severely ill and they had hypercoagulability state, or they had a virus that had spread throughout the body, then there may be necessary that they have to look up heart and liver and lungs and kidneys. But if that is a person in that kind of a state, then they would already be looking at that. So a person who has recovered after milder symptoms or more early symptoms, I don't think they need to go to get the CT scans. Zankna says, could sickle cell anemic person donate plasma for COVID? So look, plasma doesn't have cells. So the sickle cell itself has no effect in it. So the plasma can be given. If monoclonal antibodies decrease the cytokine storm, means it's working on somewhere at immune path, does that mean it also has adverse effect on antibody production? So that actually, the conjecture in this question is incorrect. The basic understanding that you are conveying is that somehow monoclonal antibodies would do something to the immune system. That is not what they do. What monoclonal antibodies do is that we give antibody from outside. These antibodies are against, let's say, spike protein of the SARS virus. So when the virus arrives or is present in the body and we have given monoclonal antibodies, then they are going to mop up, they are going to go get stuck to the virus itself and kind of mop it up. That is all they do. They're not going to modulate immune system too much, and they're not going to cause immune system misbehavior. These are just passive immunity from outside that is going to go and get stuck with the virus itself, and that's about it. So does this mean that they also have adverse effects on antibody production? No, they don't. These are antibodies given from outside. The body's own antibody production mechanism would continue to work as it does. Avox says, how could you tell if the long hauler's immune system are dysregulated? So very good question. So Avox, we do not yet have, unfortunately for long haulers, we do not even now know exactly what is going on. So we are not at a stage to say what should be the what should be the labs, or are there any specific new labs that are there for them. However, for example, if I'm a doctor and I have a person who is in long haul, and again, this would be the mild symptoms. If they had severe or critical symptoms, then the long haul may be because of the tissue damage, then those tissues need to be looked at. So maybe chest x-rays and CT scans, and then the cardiac echoes and CTs and renal profiles may be needed. But a person who had milder symptoms and recovered and now is in long haul, for them, my own curiosity will be, number one, to do complete blood count to see if their neutrophils and their lymphocytes and their blood cells are correct in number and correct in shape and maturity. That is one thing that I would do. I would also like to look at their peripheral blood picture to see what are the kind of cells and their densities and their shapes and the nuclei and their maturity of the cells as well. I would like to see that. Then it is possible to do some of the immune tests as well to see that immune system itself is functioning correctly or not. And I have for you put the link in here. This is the link. It is from primaryimmune.org, where they talk about what are various labs that may be done to understand how the immune system is doing. For example, they look at the neutrophil and look at neutrophil's function. They look at macrophages and their function. They look at the lymphocyte count and other cell counts and so on. So good question. And there are no specific labs at this time. So Rob, Florida, USA, have you seen any research on vitamin B injection for long haulers? I have not. But I know that vitamin B or multivitamin, especially vitamin Bs, have been given for strengthening and for better cell production, because we know that vitamin B12 is especially needed for making new cells, especially in the bone marrows and the nervous system, and the folic acid could be needed for that as well. So giving vitamins is not a bad idea. Co-worker husband was a long hauler, 8 weeks of complete exhaustion, bedridden. Dog gave B12 injection with supplements and steroid. Now they feel better. So again, B12 is always good. B12 is needed for the cell reproduction or during the new formation of the new cells. So B12 is good. And let's say if I was infected and my tissues are damaged and now they are recovering, they are building new cells, I would need B12, folic acid, and other such nutrients and food particles that are needed to make the cells. I think that one of the important thing here is the steroids, which are interesting for long haulers as well. So maybe the whole combination, the big gun in here is steroids. Supplements should be taken to keep our immune system correct. B12 would be taken, number one, for good strength, and number two, it is useful for the cell production and healing. Rob, I did not go through this study yet. I would look into it and then respond back to that too. Ronald says, the Russian decision to launch their vaccine before phase 3, what if we did the same? Maybe lives saved are worth the risk. Hypothetically, so he has a number that 10% of population vaccinated, 50% effective vaccine, 5% reduction in lives lost. But if we target the elderly, we can reduce by more than 5%. I think that, Ronald, we are at a stage that most of the phase 3 trials have started for at least the Oxford vaccine. So we should be able to start getting the vaccine soon. Phase 3 generally means this. Look, in phase 3, what happens is we give the vaccine to a larger population with inclusion of the people who may have comorbidities. It's just that we don't give it to everyone, but we may give it to 4,000 or 10,000 people. So phase 3 is almost going into the production. So it is possible that we should go out without phase 3, but I would, considering these are all new vaccines, considering that there may have been a risk with them if we are not fully aware of the effect on the people with comorbidities, I would like to wait for phase 3. But it's an interesting calculation that you've done. Edward says, question 1. Somehow, researchers figure out that CCR5 blockers like Leronlimab and Maraviroc attach to CCR5 receptors. Is it possible that they might also bind to other proteins that might have other beneficial effects that I haven't identified? Possible. I haven't yet heard of that. With the Leronlimab, most of the actions we've seen are with the CCR5, but there may be more studies needed to understand your question. Ivermectin damages brain tissue. If a patient is given ivermectin before onset of SARS-CoV-2, meningitis symptoms are present, then the drug will cross the blood-brain. Very, very interesting question. So the question is that ivermectin can potentially cause brain tissue damage, but normally ivermectin cannot go into the brain tissue because brain is protected by a blood-brain barrier. So her question is that what if we give ivermectin today and then the SARS-CoV-2 arrives as well, and tomorrow it causes meningitis and the meninges are swollen, and now the ivermectin has a chance to get into the brain. That is possible. Ivermectin's half-life is 18 hours. So it does stay in a good therapeutic levels for about 18 hours. So it is possible that that can happen, although ivermectin is pretty safe, but the scenario that you're saying is possible. So then somebody has responded to Paula saying there have been lots of ivermectin administered and very few deaths and so on. So thank you for the comment here, HOYT. Edward says some patients are told that their empty NBC doesn't express CCR5 and thus they aren't good candidates. So what he's talking about is the triple negative breast cancer. So in some patients, breast cancer cells, they do not have. So remember, Leronlimab have the CCR5 receptor blockade, correct? So the question he's saying is that in some cancer patients, these receptors are actually not present on their cancer cells, hence Leronlimab cannot act on their cancer. And then his question is it possible that other cells may also not have CCR5? And the answer is no, that is not correct. Cancer cells have a problem that they go and alter the cellular machinery and they start making their own things, just like virally infected cells start doing virus things. Cancer cells become rogue cells as well. They do not make normal proteins. So in these people, the normal cells, for example, macrophages or T cells, they would still have the CCR5s, but the cancer cell may not have it because the cancer cell is a rogue cell not making the right proteins. So very good question though. Paula says, VIP seems an exciting COVID treatment prospect, but it will be ineffective. Will it be effective in cystic fibrosis? So Paula, I have this So this is for Rob, Leronlimab moving towards the breakthrough designation with positive MT and NBC data. So what was that question here? This question. So Edward, please see this link. Where is that link? Here. This link may be useful for the Leronlimab and the breast cancer thing. Now, the cystic fibrosis. So for Paula, here is a study or an article on cystic fibrosis in which they talk about VIP or vasoactive intestinal peptides, for example, Avaiptadil, which I talked about a few days ago. And it says here, in the present study, we have used VIP knockout mice. So they took mice in which they had taken the vasoactive intestinal peptide hormone making cells, they had knocked them out. So the mouse was not making VIP. And they saw that this CFTR channels became worst in those mice. And when they give the VIP from outside, these channels started working correctly. So to answer your question, is it possible that Avaiptadil-like drugs or VIP drugs can help with the cystic fibrosis? Yes, it is possible. Here is an article. And I have put the links for these articles in the description as well. So then there is a question from Adam. He says, how do you feel about reports Russia has been working on this vaccination for 6 years? So I just talked about that a little bit before as well. Any country, any company that had been working with SARS-CoV-1 or MERS-CoV vaccines before, they would have a head start. I just do not know if the data about Russia. So that is just my ignorance. That is my lack of knowledge. Frank Kushner says, I received an email response from Dr. David Bolwer of University of Minnesota claiming this study shows ACQ doesn't work. Interestingly, I had actually talked about this study as well. So this was a study, hydroxychloroquine in non-hospitalized adults with early COVID-19, a randomized trial. And see, my highlights are still there. So I had talked about this study. This was an online studies, and I had some comments about why this study may not be the right study. But yes, if you look at the study and agree with the study on the face value, then yes, it doesn't work. But there are some flaws in the study as well that I had pointed out in the past. Tirialo, what are your thoughts on Avaiptadil? So we talked about it a couple of days ago. So Tirialo, please look at that. Emergency CARC looks very promising to me based on what, so that is the response. We're almost at the end of the questions. So I hope you guys are not bored who are putting the actual questions here as well. I wanted to make sure that the questions that had already been curated, we answered those. Avox says here, I'm excited for the Friday Open Forum, that is today. Dr. Bean, do you think this 3-month guideline is correct, or is it more incorrect information? This is a very, very interesting question. So here is what is happening. What is happening is that CDC says that people may have antibodies, good antibodies against COVID-19 if they have recovered from the infection for about 3 months. And I have talked about that study as well, which said that after 3 months, the neutralizing antibodies reduced by 8% and the binding antibodies reduced by 72 or 80%. So Avox, I had to do some homework for you. And so here is some homework I've done. I think you would appreciate it. So here, let me increase the size. So look, first of all, let's agree on one thing, and that is how much antibody should a person have to stay protected. So let's say if I become infected today, my body is going to make lots of antibodies. But what is the right value of antibody? That is a guarantee, at least from my body, that I can control the virus. And if the virus comes in again, I can catch it. So I have a link here so this is the link, antibody detection. And here it says, different system exists for antibody measurements, and positive tests for IgG, IgM, and IgA are generally described as greater than one arbitrary unit. So greater than 1 unit for the test. And they are saying that value of IgG antibody greater than 6.5 AU/ml correspond to an antibody titer of 1 to 320. So if a person without antibody or without virus, if we call them as 1, then 6.5 AU will be 320 times more antibodies. And if the AU is 20, then that is 1,000 times more antibodies. Now, here is an important key factor here. An IgG antibody titer of 1 to 320 has been recommended by FDA as a threshold for determining if convalescent plasma should be used in a patient. So this is the antibody titer, which is the breakdown or the level here. So what I did was this: I took, let's say I did a formula or math here. So let's say somebody today becomes sick and they have 100 antibodies, and these are neutralizing antibodies. Now, that study had said that every 3 months, the antibody declined by 8%. And they said in the study, I think I have one study here open as well, where they said, here, in this study, they said that the antibodies decay, but then they also acknowledged that it is possible that so look at this. It is difficult to extrapolate beyond our observation period of approximately 90 days because it is likely that the decay will decelerate. It is possible that decay would accelerate as well, but they have connected with a study over here that observed that the decay in the antibody actually starts reducing. So now with that, I'm going to take 8% as the decay every 3 months. So that means if we have 100 antibodies and there is 8% decay, then after 3 months, we'll be left with 92 antibodies. And then after 6 months, 84, and then 9 months, 77, and so on. And I continue to go for years. Then if I use that with the antibody recommendation, imagine if somebody becomes infected and recovers and their antibody titer is 16. Then with 8% decay every 3 months, they would go down to a level that is, let's say, not acceptable, 6.5 and above. Then that would be how many months here? 3 months and 3 months and 3 months, about 9 months. And after that 12th month is when they may start having enough decline of the antibody that they may have a problem. But there is another thing over here which is very interesting, and that is they say that the half-life is 36 days. Look at this one. They say which corresponds to a half-life of approximately 36 days over the observation period. So if half-life means when something becomes half in quantity. So if every 36 days something becomes half, then that means within 3 months, 4 months, it is possible that it has gone enough down that it may not be in sufficient quantities. But the question is, what did the person start with? And I want to throw in one more set of clarity over here. Look, we have seen in our past discussions, and Cool Beans have seen this with me, that it is possible that in some people, so let's say this is the innate arm of the immune system, innate arm, this is the adaptive arm, correct? And we have talked about it, and this is the naive T cell, this is T helper 2, this is B cell, and then this is T helper 1, and then there is cytotoxic T cell. We know that in children, for example, the innate arm is strong enough to give them immunity or protect them, not immunity, but take care of the infection. Then we also know that in some majority, at least that we are seeing, they go B cell route. But we also know that some people actually go B cell route and they also go cytotoxic T cell route. And in these people, it is possible that the antibody levels are not high enough, but the cytotoxic T cell levels are high enough, and they are helping them become immune or take care of the infection. So that means just the antibody level is not sufficient to decide if a person can become reinfected or not, and how long do they have immunity or not, because it is possible their innate arm is working very well. And that is why their antibody levels are not great, because innate arm has taken care of things. Or it is possible that their innate arm is active and their cytotoxic arm is active as well. So if we really want to see if somebody has become immune or not, and their immune system has learn to take care of the situation. Then we will have to look at their innate arm and the status of that, their antibody levels, and their cytotoxic T cell levels. These three things together, excuse me, together would tell us what is the status of the person, not just the antibody levels. So that is the discussion on the antibodies. Very good question. But again, from a opinion point of view, I would say that whatever is given as a recommendation at, let's say, 3 months, then we should take that, because I would not like to tell someone that, hey, I think it would be for 1 year and then they become reinfected. So if it is 3 months given in CDC, then we should just take 3 months as the time for which the immunity is available. Good question, Avox. Then there is another question from Avox. How does the virus get around in the body? Very, very interesting question. And let me just very quickly talk about it. How does the virus get around in the body? So let's say this is a virus, coronavirus. It appears and connects with our upper respiratory system. There are a few ways for this virus to get around to the rest of the system. One, it can actually just continue to go from cell to cell all the way to the deeper tissue, all the way to the lungs. That is one possibility. Another possibility is that macrophages will eat up this cell. Then, so let's say somewhere over here in my mouth area, the cell was present, the virus was present, it went into a cell, macrophage came and they ate up the virus or the cell. Now the virus is inside the macrophage. These macrophages are then going to run towards the nearby lymph nodes and present the antigen to the T and B cells in the lymph nodes. Then, as the macrophages are in the lymphatic channel, from there they can actually go to the blood system, and through the blood system they can disseminate to the rest of the body. So there can be local spread, that is from virus from cell to cell, or there can be a lymphatic spread, or there can be from lymph to the blood and then from blood to the rest of the body. So there are many, many ways that the virus can spread, but these are generally the ways a virus can spread. Then there is this, do you think that the paper test can be made would help? So there is a Medcram video over here. Unfortunately, I had tried, fortunately I had tried Dr. Saluth to join us, but he has not responded. I would have loved to have him. I would look into this AVOX and see what is the discussion there. Luke says, what is your opinion about it? And this is a paywall link, so I could not actually read it. So hopefully, Luke, if you can actually look into the article and tell me the specific question, I can talk about that. And then Zankna says, if an infant gets infected by COVID-19, what are the primary treatments for them? What is the time of this forum? So the time of the forum, 6 p.m. I am not a pediatrician, so I would totally avoid this question because this is a question for a pediatrician. I cannot answer this one. Okay, so this is the discussion here. My apologies for the rest of the team here. Are you okay? We are 1 hour into it. Should we stop now or should we continue? And I'm going to look into your questions. Your call. So Brooks says, do you think Leronlimab will get FDA approval? This I have no idea. I wish that they can get some approvals and they have a chance to help further, but no idea. So 008 KLM says, are there macrophages around the eyes? Macrophages are everywhere. So what happens is our bone marrows, so let's say sternum or the body of the vertebra or upper parts of the humerus, upper part of the femur, hip bones, they make monocytes from the bone marrow. Monocytes are in the blood. From the blood, they eject out, they come out and they become residents. This is Kyrie, not Luffy. Kyrie has a more polite voice. So the monocytes come out of the blood vessels and they go into the tissue and they live everywhere in the tissue. And these are the dendritic cells or macrophages. So yes, to answer your question, yes, there are macrophages in every tissue, everywhere. So I'm trying to go through this and looking at the questions. Luffy said your time is over. Yes, so this was not Luffy, this was Kyrie. Stray cat named Feral, very good name. Is it correct that the lymphatic system is sluggish or poor? This can affect the ability of immune system to have speedy and efficient response. So is it correct if lymphatic system is sluggish or poor, ability of immune system to have speedy? No. Actually, lymphatic system should be working correctly, because what happens is the macrophages and the neutrophils, macrophage especially, they can pick up the pathogen and then they rush to the lymph nodes and they present the pathogen over there, the antigen. So give me 1 second, please. My throat is dry speaking. So the immune system, the lymphatics have to work correctly and fast so that the macrophages can reach there. They already take days to reach there. And if the lymphatics are slow or sluggish or not working correctly, then we would be in trouble. Question. Reality says, how would you treat COVID patients who have adrenal insufficiency as a comorbidity? These patients are already on 20 milligram hydrocortisone, split BID or T. How does this relate to Math Plus protocol? So very good question. Look, this question has been asked many times. And please realize that if somebody has adrenal insufficiency, that means their normal steroid level, which is present in all of us, that normal level is not maintained. And so they're taking medicine from outside to compensate for that normal levels. So taking steroid from outside at that time is not acting as extra steroids. So because of that, if you have kept your levels normal, you are acting as a normal person as well. So then if more steroids are needed, that would be needed on top of it. And that steroid that you are taking will be considered as compensating for normal levels. Okay, so I'm just going through this and seeing if there are more questions. There are so many comments. Thank you all very much. And please do me a favor, do like, subscribe, and share. And I'm looking at the word question in here. Question. So Reality Check has one more question. So I just answered this one. Man, the comments are scrolling so fast. Or maybe Reality, you have written the question multiple times here. More questions. Okay, good. Can the virus affect only digestive system? So Abdu says, can this virus affect only digestive system or respiratory only, and how they depend? So we have done this discussion many times. The ACE2 enzyme are present in the respiratory system, heart, blood vessels, kidneys, GIT, and brain. So all of these tissues can be affected. Usually the virus cannot go to brain because of the blood-brain barrier. So brain is usually not affected, but anosmia has been observed. And the reason for that is that the olfactory nerve is actually part of the brain. And that is sitting here at the roof of our nose. And it is a naked tissue of brain. And virus can actually attack it and cause anosmia or inflammation of it. But it cannot go to the rest of the brain usually because the brain is protected by blood-brain barrier. So to answer your question, respiratory is the most common, but GIT is very common as well. Then anosmia is common as well. Then myalgias, fatigue, renal issues, cardiac issues, blood vessel issues can all be seen. So then there's a question by Caroline. Do you think monitoring serum cortisol, ESR, CRP, and periodically could be helpful for long haulers? Absolutely. So I am actually complete blood picture, ESR, CRP, ferritin, D-dimers, to understand what is the situation of the immune system itself, and then to understand what is the oxygen levels. These would be very interesting to know. Could monoclonal antibodies or another med be given until levels are normal? So of course, monoclonal could be given if they are available, definitely. but it really depends upon long hauler. What is the basic problem with the long hauler? Is it tissue damage that is healing, or is it the dysregulated immune system, or is it the virus still percolating in the system? If it is immune system, then we'll have to give immune modulators or steroid-like things. If it is organs healing, then we'll have to give things like vitamin B12s and the other supplements and good food and rest and oxygen and water and those things. And if it is virus still there, then monoclonal antibodies and other such things may have to be given. It is such a shame that we are not very clear on how the long haulers are suffering or what is really going on. I'm going to do some research to see if I can find that answer. So there is a question by Diversity. Cancer treatment, I read about they removed the organ and irradiate it. Would this work on a virus? So I had done a talk about low dose radiation. So please, if you look at my videos, there would be a low dose radiation video in which I think somewhere here in the US, what they did was they irradiated the lung area with low dose and the patient started getting off the ventilators. So this is possible that it would work. Kyler Bond question, have death rates improved by and by how much? This is a question that I've not looked at, and again, what country and what geography. Kyler, I can look at it and we can do a world status as well in terms of death rate. I think that the death rates are improving, or by improving, I mean reducing. I do not know how much, and I'll have to look at some of the data there. Question, Logic says, what dose of N-acetylcysteine should be used? Do you believe this will prevent hospitalization in theory? So N-acetylcysteine has two basic functions. One, it is a sulfur bond breaker, and so that breaks the mucus plugs. Secondly, it is an antioxidant, and in that vein, it also helps make glutathione as well, which is also antioxidant. So as long as antioxidants are needed, N-acetylcysteine is very, very useful. Can it prevent a person from going to the hospital? That I cannot say, because it is not just the reactive oxygen species. There is so much more damage and immune dysregulation that is happening that just blocking the ROS will not be sufficient. Debbie says, it's the virus. I vote for viral persistence for Dr. Bean. I've had many chronic viruses lasting years, perplexing doctors until we get on the right. Yes, and if it is a virus persistence, maybe the statins with steroids or maybe monoclonal antibodies will be useful. ITJ says US July death rate report 1.35%. That is much better. And is this the number for the overall population, meaning number of deaths divided by the total population, or the confirmed cases? Marie says, question, can the coronavirus stay infectious on dry surfaces for up to 3 days when it is supposed to die if it does not stay moist? So the very good question. I was talking about someone about this a few days ago as well. Look, it depends upon what the surface is. If a surface is porous, it has pores in it, then the surface is going to absorb the coronavirus's moisture as well. And that is going to shrivel and destroy the virus much earlier, and the virus will become less viable earlier. If the surface is polished and clean and the environment is moist or environment controlled, for example, air conditioned and all that, then the virus might survive there for a longer period of time. So less porous surfaces, for example, metallic surfaces or plastic surfaces that are polished, the virus can survive there for longer. Of course, the dry environment is more fatal for this, more deadly for this virus compared to wet environment. So dry environment can cause the virus to become less viable soon. But if the dry environment and the surface the environment is moist, surface is polished, even when dry, can allow the virus to stay viable for a longer period of time. So I will, Brooke says, what about the rapid antigen paper test? And there was a question there as well on Twitter. I will actually do a talk about this probably tomorrow or next week. Good question. So there's a question about, Partha says, TMPRSS2 inhibitor status. So it is interesting that some studies are now saying that chemostat mesylate doesn't work. Some studies are saying they do work. Same is the case with the bromhexine as well. So I haven't seen yet any positive, significantly positive study that says they would work. So Diversity Love says, no one knows how to wear a mask, so I walk around with a Mr. bottle of alcohol. Okay. So the gamer one says, did you have a discussion on the theory of innate immunity of people being exposed to common cold are the ones who are asymptomatic on COVID-19 now? There is a MedCram video about it. Sorry for spamming. No worries for spamming. I will have to look into this topic and discuss it further. Good topic though. So there's an interesting question here. Do you think that the quercetin or EGCG as zinc ionophore have the ability to reach a high enough plasma concentration to aid? So the problem is to understand what is the exact zinc amount that needs to go into the cell and what would be the ionophore's quantity available per dose. And I am not sure what exactly is the dose. Even for hydroxychloroquine, in therapeutic doses, we've seen this to be working correctly. But exactly out of all the functions hydroxychloroquine does, what part is the ionophoric function and what part is the remaining function, we do not know very clearly. So what I do is, for my own self, I take quercetin with the on-label dose. So Randy says that does iodine have an antiviral effect? And I have done this discussion before as well. So iodine is, of course, antiseptic. It is one of the most popular antiseptics as well. Plus, it is used for the wound cleaning in surgical environments too, or the skin surface cleaning, skin cleaning. So it is a very potent antiviral and antiseptic. Now, taking that, would that help or not? I don't think so. So Reality Check says, if patients are recommended to have 100 milligram with rise in temperature, 100 milligram of what? How does this relate to math viral stage? Would it be immunosuppressive at that stage? Reality, which drug are you talking about? Iodine? Yeah, so Lugol solutions are better, correct. So Logic says, I want to add that for people who take quercetin, that it is important to add vitamin C, as quercetin will have pro-oxidant properties. Perfect. So perfect, guys. So this is it for today. We are 1 hour, 12 minutes. I can continue talking with you for a long time, but I think this is a good time to break. So my request to you is that please like, subscribe, and share. My apologies. I have not been able to reply to comments for some days. And I would try to, over this Sunday, I would try to go over them and respond. Cool. So thank you very much. Have a good day. I'll see you tomorrow. Stay safe and healthy and happy.